Okay, everybody. Well, welcome to the Teaching Value webinar series for our Learning Network. We're very excited for this particular installment. This is a series that we have been thinking about and sort of working towards for a long time now, but this is the third one in the series. And I think in June of 2015, we're at a point now where we're not only talking about this volume to value shift in aspirational ways, but we're at a point in the healthcare system where it's very clear that there's tremendous pressure, I think, from payers and regulators and purchasers and also patients to hold us accountable for doing this. And between the ABIM Foundation and cost of care, we felt very strongly that medical educators are, of course, a really key portion of this transition. And that was really the impetus for setting up this learning network. So the learning network has three components. There are these monthly webinars. Welcome back to those of you who have been on these webinars in the past, and welcome for those of you for whom this is your first time. We try to alternate between what we think of as national leaders, people that are working through national organizations, as well as people that are working on the ground in their own institutions. Today is relatively unique because we have a mix of both. Beyond the webinars, if you go onto the Teaching Value Learning Network, you'll find discussion groups. You'll see people sharing specific tools for educators, as well as trying to troubleshoot issues that come up and trying to think about how we educate our trainees to do this. Today, we have three objectives. We're going to share a specific innovation in teaching value. We're going to discuss some of the practical components of how they put it together. And then we're going to think about how we go about making this sustainable and also scalable at other organizations. And we'll, in particular, really look forward to your questions and bringing that into the discussion. So today we are very excited to have a group of speakers to present their SOAP V innovation. We have Eileen Moser and Susan Glad from Penn State. We have Grace Wong from Beth Israel Deaconess and Harvard Medical School, and we also have Daisy Smith from the ACP. I should mention that in addition, their additional collaborators include Sarah Fazio from Beth Israel Deaconess, as well as Clifford Packer from Case Western Medical School and the Cleveland VA. So we've got a very large and inter-institutional team. I'm going to move over now to our screen so we can get started. So Eileen, maybe I'll start with you. I think what we'd love to hear a little bit is just the genesis of how this team came together from so many different institutions and how the idea from SOAP V kind of formed.
Sure, and thanks, Neil, and for the opportunity to be here, and hello to everyone out there. This really came out of the Millennium Conference, and Grace Wong was a major impetus in putting the Millennium Conference together, and it was on high-value care. And as we sat around the room, we struggled with how in the world are we going to teach our students high-value care, and we quickly came to the conclusion that, like any good education, it has to be more than just the concepts. We need tools to do this. And as we were thinking about this, we also wanted to really empower the students to be change agents as far as bringing high-value care really to our institutions. We all recognize that our institutions a few experts, but by and large, most of the faculty have not been taught to practice high-value care. I think this is one of the major struggles in really teaching this to our learners. And as we were thinking, we came to the idea of SOAP V, which is really a cognitive forcing function, and very simply it adds the value to the traditional SOAP note.
Great. Yeah, that's wonderful. And in particular, how did you find your collaborators? You were at this meeting, and was it just sort of luck? Were you working in a focus group together? How did that come about?
Yeah, so the Millennium Conference is a group of schools, and we all apply, and a number of schools had different proposals on high-value care, and for me, Penn State, we included. It was a wonderful brainstorming ability to come up with different ideas at the same time. And I should add that at the Millennium Conference, besides the Shapiro Institute that puts these together every 2 years, we also had the American College of Physicians. It was a co-sponsored event, along with a number of medical schools. I think there were maybe somewhere between 6 and 8 medical schools. So yes, there were all different groups, and it was in that brainstorming kind of event that I had this idea of SOAP-V. Because see, the thing is that when you think about this, we all want to do this. We all want to add value to our medical decision making. But part of the problem is we really don't remember to do it. And so how are we going to help our learners of value and actually put those questions in and embed the questions in? So, you know, when you think about it, we already teach our students evidence-based medicine. We already teach them, why are you ordering the next test? But why aren't we teaching them how also cost interplays? And why aren't we teaching them really about the downstream effects of what we're doing? And are we really emphasizing the importance of considering patient values in our decision making? So we ultimately came up with 3 questions as part of the V for value. And the first question is, you know, what's that test going to offer you in the long run? Have you thought about whether it's going to change management? Have you thought about the evidence behind that test? That's question number 1. Question number 2 is the patient. What does the patient want? Maybe the patient doesn't want the very invasively add value. Maybe it's not in alignment with what the patient holds dear. Have you had that conversation? That's question number 2. And question number 3 is the relative cost. So are there other tests that are less costly but still have great outcomes? And also think about the downstream costs, including harms to the patient. We all that brings forward more and more testing. So 3 questions, all embedded in value, and I would argue those are things we should be doing anyway with our patients, and they're really...
That's great. Okay, so there's a lot to unpack there, and I think, you know, just to be clear for everybody who's listening, so the idea of SOAP-V is taking what everybody knows as sort of the template for an inpatient progress note, a SOAP note, and then adding this additional component of value. And then you just sort of decomposed what value means in terms of these 3 questions. One of the things that you mentioned, I really want to get Daisy in here too, because I know she's on the webinar as well. And one of the things that you mentioned is that you were thinking about not only how to educate students about value, but thinking about them as change agents with recognition that faculty are not necessarily, they don't think of themselves as having expertise. Although you did also mention that these are things that we probably ought to be thinking about anyway. And so you were sort of thinking about using SOAP-V not only as an educational tool, but as a way of perhaps providing some agency back to the faculty. And I know Daisy has been thinking a lot about national curriculum for internal medicine around value and trying to bring faculty up to speed. And Daisy, what are your thoughts on that?
Can you hear me?
Yep.
Okay. So I do think that faculty development is a huge issue with this. And when the idea first came up, we were worried about putting students as the change agents, whether they would come up with some resistance. But I think the findings, which Eileen and Grace can talk about later from the study that we've done, show that actually it's quite empowering for everyone on the team. So I think this is a nice opportunity to promote what we call co-learning, where multiple members of the team can learn how to do this together, and it helps really make a more lateral, flexible, fluid leadership and learning atmosphere and culture on the team. So it can be really team building. I don't think, I think we still need, it's not an excuse not to do faculty development, because I still think we need to do significant faculty development on a national scale around the provision of high-value care. But we were really pleasantly surprised with the results.
Great. Okay. Well, then let's just go back a little bit in timeline. So this team formed at the Millennium Conference in 2013, and then my understanding is that in 2014 you started to roll this out and actually implement the idea. So you spent, a good part of the year adding some specificity to it, adding some tools, and then at all of your different sites, and Penn State, at Harvard, at Cleveland, you started to roll this out to medical students. And we'd just love to hear a little bit more about your experience with that and sort of how you operationalize this idea of change agency. Like, what does the conversation between the student and the faculty look like in these settings?
Yeah, this is Eileen. I think the beauty of this, Neil, is that you really can do this and have the student drive the conversation. We're not relying on the faculty member to bring the concepts up. Having said that, it is important for faculty to at least be open to the conversation, because what we don't want is a roll of the eyes that can really degrade the student trying to bring these concepts up on rounds. But we thought very long and hard about who our intervention group was, how we were going to deal with faculty and their influence, and so we did feel that it was necessary to have just a minimal, very short intro to our faculty about SOAP-V, so that they would know that they're going to hear it. So that we did significant faculty development, but we did introduce them to SOAP-V and say, you're going to be seeing this on rounds. But again, the students are the ones who are driving this. Did that answer your question?
It does. I'm just sort of curious what the faculty reaction was. I'm sure it might have been variable to some degree, but beyond just giving them the heads up that this is going to happen, was there anything else you did to sort of prepare them in terms of thinking about why you're doing it, or just some background, or were people already kind of there?
Neil, this is Sue.
I think it's really variable, and go ahead, Sue.
My name is Sue Glad. I'm the clerkship director at Penn State, so I did a lot of the faculty development. I think initially some of the faculty were a little bit trepidatious in that they were concerned that this might appear as though we were questioning their clinical approach. I think once we got a month or two into the curriculum and the faculty recognized that the students were really bringing up great points, and discussions were happening that actually ended up improving the care of the patient at that moment. I think the faculty came on board very quickly, and the residents came on board very quickly, because the residents and faculty tended to be in a mindset where we would do things because it was the policy or because it was just sort of the way we had already done things, and the students had that fresh approach where they could ask the question, why are we doing this? And that would sort of cause everyone to pause. And patient outcomes, I think, were not perceived as any worse. Some patient outcomes were perceived as better, and so people came on board quickly, and it was not an issue after the initial rollout.
Okay, I'm just going to say very quickly, I could talk to you guys about this all day, but I just want to mention that anybody who's out there listening can feel free to throw out a question at any point, and we'll be sure to try to integrate it into the conversation. So don't hesitate if you've got some burning questions as well. But one of my questions, and just sort of thinking about this, is, part of the utility, I think, of this way of formulating talking about value is that you can see the way it might be naturally integrated into rounds and other parts of the informal teaching that sometimes happens. But just to be clear, your sort of target intervention group was third-year medical students. Is that right?
Yes, that's right. That it doesn't have to be third-year medical students. We just from a sort of a study design point of view, we kept it narrow so we could measure outcomes better. But there's no reason in the world that this could not be extended to residents, nurse practitioners, physician assistants, etc.
Or even different specialties, right? You were focused on internal medicine.
Yeah, again, we decided, so our group, when we came together, our group was a mixture of different specialties. We had everything from OB to a nuclear radiologist to internists. And we all saw the utility of SOAP-V. But again, when it came to study design and going across institutions, we felt that staying in one specialty would help the design and make it a
Got a little bit of a connection issue, I think.
I don't hear you.
Okay. Well, one of my I think next questions would be, and this might be a little bit of a pointed question with, but that's what we're here to do, is to sort of troubleshoot. So, did you guys experience any differences across your institutions? Because I imagine, you know, Case Western and Beth Israel and Penn State are pretty different places, and every place has its own culture. And as we think about the volume to value transition, institutional culture is often brought up as one of the biggest barriers or enablers. So did you guys notice any of that? You don't have to name names.
So Neil, your question is what differences we saw in terms of outcomes, or was
Right.
I might have I'm having a little bit of a connection problem, so I didn't hear your whole question.
That's right. Just differences between institutions.
I'm not sure we saw differences between institutions. What we did see is we saw differences pre versus post. I mean, I think all of our institutions, probably throughout the United States, are struggling with the same issues. It may be a little bit more, a little bit less, depending upon how far along our institutions are in going from fee-based to value-based, but we're all struggling. So when we came together and talked about issues, I think they were all similar. But you know, Grace, I'd love to hear what you have to say about that.
Neil, it's so this is Grace Huang. I'm a hospitalist at Beth Israel Deaconess in Boston. Just so you know, we are finishing up the third year for 2 of our sites, so not all of our data are in. And I think one of our major analyses will be to look at differences across sites. For instance, one of the sites was at the VA, so their system is going to be completely different. And then, for instance, at the Beth Israel Deaconess, we had controls and intervention students at the same hospital, whereas the other 2 sites were comparing clinical training that's going on in 2 different clinical sites. You know, anecdotally, it also has a lot to do with the structure in which the care and the teaching is delivered. For instance, at the Beth Israel Deaconess, the teaching is predominantly the hospitalists who tend to be younger, who have really bought into this concept. We also have a structure and a culture that is centered on residents who drive rounds and drive a lot of the decision making. So I felt that our culture seems to be taking this up very easily, and I think our data will show whether there were any significant differences across sites or whether we all struggled with the same opportunities and challenges.
That's great, and I think, you know, it'll be interesting for us to follow up with you on that, because as we think about how innovations like this are scalable, often there's a lot to be learned about differences in institutions and thinking about why things may have been a little bit more sticky in one place and a little bit, you know, more challenging in another. We've got a couple of great questions that have popped up. The first one is from Lakshman Swamy, who is a rising chief resident at Boston Medical Center and one of the co-chairs of the next IHI National Forum. And he's asking, I think, a very good question, which is that sometimes, honestly, third-year medical student presentations are already pretty drawn out in inpatient medicine. And I would think that that'd be a pretty big barrier just in terms of time. What did you guys find?
I think, so this is Eileen, I appreciate that, and that's one of the reasons that we created the video showing within 5 minutes how a student can give a whole presentation and get feedback from a faculty and include value. What I really would like to emphasize is that the value question really is part of the whole presentation. I mean, I think, although we say SOAP-V, I really don't think of it as an add-on. You know, it really is what we should be doing anyway. And you know, it doesn't have to be increased in terms of the amount. I think in order to sell it to your institution, one thing that we did is we encouraged the speak, and that might be an easier way of kind of bringing it in so that there's less concern about time constraints.
And was there any concern? Another question that's come up is there any concern about how adding this value dimension during a time in a trainee's education experience where they're climbing such a steep learning curve might add an additional layer of complexity? And was there any concern that this might actually make it more confusing to learn the basics of inpatient medicine if you're trying to think through a plan but also questioning why you're doing it and going back and forth?
This is Grace. Anecdotally, we noticed this in the beginning of the year, that the students are now really practicing their skills live, and they struggled a little bit initially with value, but in our focus groups, we've heard how much easier the concept of value was once they had gotten the basics of presentation and some of those anxieties away of being on rounds and presenting their patients. So I do think that there is a maturation issue in a high-level concept like value, that they sort of need to get some of the basics down. But that being said, I think these questions about, does this change management, does this put the patient's preference at the center of it, I don't think conceptually these are very hard for anybody to grasp.
That's very interesting, and the idea of maturation, I mean, that makes sense. I mean, there's maturation in clinical judgment in general, so you'd sort of expect that, and in some ways it's kind of nice that you're observing people climbing that aspect of the learning curve as well and getting better at it. So our next question is from Reshma Gupta, who is the director of this learning network and also an RWJ clinical fellow at UCLA. And she's wondering, have you seen, sort of think of these as spillover effects. She's wondering, have you seen other folks on the care team, whether it's respiratory therapy or nursing or other folks, get influenced by the new dynamic that you're kind of setting up by making value discussions explicit?
Well, that's actually part of our data. So we have pre versus post survey data for that we've collected from residents and attendings, in the hope that this program has somehow changed their attitudes about high value care, as well as we know it's being used, but does it actually change and attendings thinking about high-value care? So no data ready yet. I don't know, Grace and Sue, if you'd like to comment anecdotally what you've seen.
This is Sue. I would say that, and again, anecdotally, having been on service for the past couple of weeks, I think the real meat of this is not so much the action, but the discussion around whether or not we're going to do the test or whether or not we're going to order the procedure. And so when that discussion happens in the presence of the interdisciplinary team, I think it shifts everyone's focus a little bit from this person is confused, so they really need a head CT scan, to what can we really do to improve the outcome for this patient, and is test A, B, or C going to get us there, or is it going to to cause more problems for this patient in some way. And I think, honestly, giving the interdisciplinary team the opportunity to observe that and to participate in that was really valuable for the care of a lot of the patients on our service that we served over the past 2 weeks. Because it really brought the patient into the center of the discussion rather than whether or not we should get this test.
Great. And as we sort of come up against the end of our half-hour discussion, I just wanted to give all of you the opportunity to maybe share some of what you've discovered along the way. So, Eileen, you mentioned that, everybody is sort of struggling with how to navigate this transition in the healthcare system. And there's a sense that we're on the precipice of some kind of radical shift, but it's not exactly clear when it's going to happen. And in many ways, you guys are way out front in terms of trying to teach medical students and prepare them for this whenever it is going to happen. My guess is that in the process of being way out front with this, that you've encountered things that were surprising or nuggets of wisdom that you didn't expect that you think that maybe other folks in this learning network might benefit from. So I'll leave that as a general question to kind of toss out anything that you'd want to share with the learning network based on your experience.
Am I muted? Am I muted? I think I'm muted. No. Okay. All right. So for me, some of the surprising things even came early on when we looked at student attitudes. So for me, I was really pleased to see that students felt that physicians really ought to consider costs, consider patients' point of view, and that the part of this move to really fix the economic healthcare environment that we practice in. However, did not feel comfortable having these conversations with patients. They did not feel comfortable having these conversations with their team. Making costs to pay. Even fewer were considering costs to the system. So some were, that was usually for patients who didn't have health care insurance, but very few were really considering costs to the system. So while they realized that it was important to really practice high-value care, they in fact didn't feel like they had the tools, and they in fact didn't feel comfortable with high-value care. So our 6-month data after we did this, and it's preliminary, but it comes in our survey, so did report an increase in their perceived power to address the economic health care crisis, and they did feel more comfortable initiating a discussion about unnecessary tests and treatments with their team. And they also agreed that they were more likely to consider potential costs to the healthcare system in their clinical decisions. Prevention group. In the control group, there was no change. So it's only 6-month data, but I thought that was was really validating in terms of that. Maybe there's something here. In terms of bringing these value discussions and giving students the tool to do it.
I think that's fair to say, for sure. I mean, so, I think that also very much resonates with what I'm seeing nationally, and I'm guessing what Daisy is seeing nationally as well, which is that there's tremendous interest and desire on the part of trainees, I think, to learn more about this, and a sense that in the absence of the kinds of innovations that you're bringing forth and other people in the Learning Network are bringing forth, we're not adequately preparing them. And I think that students recognize that for sure. And I think one of the most encouraging things from what you've been able to do is, even with 6 months of preliminary data, you're starting to change people's perception of their, even their sense of empowerment to do something about this. I think often physicians feel like victims of the healthcare system, and our emerging trainees hopefully won't feel that way if we prepare them for some of these changes. And clearly that's what you've started to do. So I'd just really like to thank Daisy, Eileen, Grace, and Sue for taking the time to share their wisdom with our Learning Network. Thank you for everybody who joined in. This video will be archived and available at Learning Network for people to come back to and view, and we will very much look forward to following up with you and learning the results of the full 12-month study.
Fantastic. Thanks, Neil. Thanks for the opportunity on behalf of our whole team to talk to you today.
Great, thank you. And for the Learning Network, we will see you for the next third Thursday Hangout in July. So until then, thanks very much. Have a good afternoon.